So in general, diffuse large B-cell is the most common lymphoma. There's around 80,000 new cases of non-Hodgkin's lymphoma a year, and about 30,000 of them are diffuse large B-cell lymphoma. So to put that into perspective in terms of other cancers like breast cancer or lung cancer or colon cancer, prostate cancer, those cancers have 200 to 300,000 new cases a year. So while diffuse large B-cell is the most common lymphoma, it's still a relatively rare lymphoma. We do know that there's some risk factors for lymphoma. So our patients who are immunocompromised, patients who have HIV, patients who have had a prior organ transplant and are on immunosuppressive therapy, patients who have chronic infection like EBV, HTLV, CMV, EBV, we know that these are can cause lymphomas, and obviously any autoimmune conditions where patients are on long-term immunosuppression. Some of the new drugs that they have in rheumatology, also, their goal of those drugs is to suppress your immune system, and sometimes those have been associated also with lymphoma. One thing that is interesting is that while the incidence of other cancers is actually increasing, the rate of new diagnoses of lymphomas has actually remained relatively stable over time. So after we understand what kind of lymphoma you have, the most important thing to do is stage the lymphoma. In terms of cancers, I think lymphoma is one of the easiest to understand in terms of staging. The stage 1 is very localized disease. It's just one area of lymph nodes that have lymphoma. Stage 2, you'd have 2 areas, but they're both above the diaphragm. Stage 3, you can have lymph nodes that are above and below the diaphragm. And stage 4 usually involves an organ or bone or is just widespread disease. What I think is really important for patients to understand is that even if you have a stage 4 lymphoma, it doesn't mean it's not a curable lymphoma. So the staging is very different than a solid tumor cancer, where you in general we think about if it's already spread to multiple organs, we generally think of it as not curable. But I always tell my patients that it's very important to understand that even if your lymphoma has spread, it's still potentially curable. So the other thing that we look at in terms of deciding treatment options for our patients is we look at something called an ECOG performance scale. This helps us sort of determine, the functional status of our patient and the types of therapy that we can give them. Together, when we look at the staging, we look at the ECOG performance status, and we look at age and some lab values, we determine something called an IPI score, or International Prognostic Index, which again helps us just understand a little bit better how aggressive this disease is and how aggressive we can be in treatment options. So one of the most widely used treatment regimens for lymphomas is R-CHOP chemotherapy. So our CHOP itself has been around since the 80s. It's almost been the standard of care since the 80s. We added rituximab, I believe in the 90s or early 2000s. And basically, this regimen has been the standard of care since then. A lot of different studies, which I'll discuss in the future, have tried to improve upon this regimen, and most of them have been largely unsuccessful. So when we say R-CHOP, it's a combination of chemotherapy and immunotherapy. So rituximab is a type of immunotherapy. It attaches to what we call CD20 markers, which are on the B cells. And it helps activate, your immune system to help fight those lymphoma cells. We also have 3 chemotherapies that are involved called cyclophosphamide, doxorubicin, and vincristine, which all have very distinct toxicities. And we give the patients high-dose steroids. So a lot of times patients can have a lot of symptoms just from the steroid that we give them. This is obviously, you can have some agitation. People get very hungry, which for some of our patients is actually a good thing. And you must be careful, obviously, if you have diabetes, because it can make your sugars very high. So I'm just going to briefly go through this slide, but basically Like I said, there's been multiple attempts to improve on R-CHOP chemotherapy. People have tried to intensify regimen. So normally we give R-CHOP chemotherapy every 3 weeks. They tried to give it every 2 weeks. That did not prove to be successful. They tried to change R-CHOP to a newer version called obinutuzumab. That was not successful. They tried to add drugs, other oral agents that are newer to the regimen, and largely that was also not successful. And they tried to add additional chemotherapies to the regimen, and that did not actually prove to have any benefit for our patients.